Kussmaul sign. Okay, Kussmaul sign. This is on your boards. Okay? It's a rise of your JVP with inspiration, which doesn't make sense. I take a big deep breath in. What happens to my heart? What happens to the venous return? It increases. So my JVP should decrease because it's going into the heart. Right? So there should be less blood backing up my jugular. Less in my jugular. There's more in my heart. So it actually should decrease. That's normal. So if someone takes a deep breath, you should not see their jugular raise. You should actually see it go down a little bit.
Is this related to the Kussmaul breathing or just two totally separate things?
Same guy.
Same guy?
Same big guy.
Okay.
I think. I'm not sure. I just made that up. But I bet it is.
Same guy.
We could probably Google that, but I bet it is the same guy. Yeah, you can see someone's jugular. You'll see it. If you turn their head, you can see their jugular. You can't see it standing in most people, but if you lay it. Palpation. By palpation.
Sounds really weird. How do we differentiate this cardiac tamponade from somebody who's like taking IV drugs and you can see the jugular stuff there too?
Ask me one more time, I'm sorry.
So how would you differentiate between it being a cardiac tamponade or if somebody is like taking heroin or something through IV drugs where their jugular is anyways pulsating, like it looks like it's really raised and bumpy?
Well, I'm not sure what you're asking, but I do know this. If you get a raised jugular period, you better go looking for something. Okay? So, and we're going to talk about where a jugular should actually sit, where it's normal. So a raised jugular is a sign of something. Okay? But if you see Kussmaul, then you're going to think constrictive pericarditis and cardiac tamponade. Now, it is difficult, let me just go back to the carotid. It is very difficult to see in some people. So you can palpate all of those pulses. That question, you can palpate them all. Okay? It is very easy to do that. But make sure when you do it, don't push too hard. Okay, but you can inspect it too. So let's measure it. We're going to measure the pressure, the jugular venous pressure, which gives you an estimate of the central venous pressure. Okay? Which tells us if there's some disorders. Do we have left-sided heart failure? Is it elevated because we had lung disease that caused increased pressure in the heart? Okay? Do we have pulmonary hypertension? Do we have pulmonary stenosis? Okay? So we're going to look for those things by measuring the JVP. Okay? So how do we do this? So what you want to do is, if I stand and I have normal fluid, or I don't have anything wrong, you will not see my jugular venous. It's usually below my clavicle. So most of you sitting here, I'm not going to see it. But if I lay you at 45 degrees, I can usually see it. It comes up above the clavicle. Some people may not, maybe even below it, but they usually don't have a lot of fluid in it. So when I lay them at 45 degrees, I'm really good at hitting that button. I am going to see the top of that wave, right where the jugular is beating. Beating's a bad word, but I can see the pulsation of it, wherever it's at. And what I'm going to do is I'm going to take my ruler at the top of that meniscus and come straight out, or horizontal to the ground. Okay? Parallel to the ground. And then I'm gonna drop another ruler, so this can just be a straight edge, I don't care. I'm gonna drop another ruler right to the sternum notch. Okay? And I'm gonna see the distance from the sternal notch up to this meniscus line. Okay? And that tells me what the pressure is. Okay? So it tells me the pressure above the sternal angle, the sternal notch. Okay? You guys know where that's at, right? You can feel it. And it should not be greater than 2 centimeters. If it is greater than 3, sorry, it's greater than 3. What we have is more fluid. We have fluid that is backing up. It's a huge sign that we have congestive heart failure. In fact, that's what most people use this measurement for, is to check congestive heart failure. It'll tell us, the higher it is, in fact, it tells us how bad congestive heart failure is. But you just measure it to see if it's elevated. So, greater than 3, we have what? The JVP is greater than 3. Okay. I also want you to know this, the method of Louis, because you will see it documented. Method of Louis. I do the exact same thing, except I add 5 centimeters to it. Okay? Because 5 centimeters is the depth of that sternal angle to the right atrium. And it's 2 different methods of telling you what the pressure is. Okay? It's 5 centimeters or it's 8. They're exactly the same thing, but you have to document what I did. So I either wrote, if I measured at 3, it's 3 centimeters from the sternal angle, or the method of Louis produced 8 centimeters. No. It doesn't matter. They can breathe the whole time. You have them turn their neck a little bit so you can see it. When you guys do this, you'll see it. You just lay it down flat, because that'll kind of engorge it, because you guys aren't used to this, seeing the jugular. Just lay them down flat, let it engorge, because right, the backflow will be higher. And then just put them up to 45, and then see it come down, and that it'll stay about the same the whole time, and then measure it right off that. Okay? There's another test. Okay? The abdominal jugular test. They've renamed this. It used to be called the hepatojugular reflux. There's a lot of different ways to do this, but this is the right way to do it because I'm teaching it. No, this is what's in the books. Okay? So what you're going to do is you're going to lay a person down. And it doesn't matter what position they're in. 45 is the easiest to see a patient. So put them at 45. If they're sitting up, maybe a little bit clavicle, I can't see it. If they're laying down, it may be up so far you can't see it. So put them at 45 degrees. All you want to do is put pressure right below the rib cage in the epigastric region. Okay? So you hold it for 10 seconds. Someone who has normal pressure, central venous pressure, or doesn't have fluid overload, or doesn't have congestive heart failure, okay? It may go up for a couple strokes, you'll see that, and then it immediately goes back to its normal. But someone who has those diseases, that disease state, it'll go up and it'll stay up. okay? So you'll see it raise up quite a bit. It's pretty incredible. Stay up the whole time. That's a positive test. If it goes up about 4 centimeters and stays up. So what am I doing to that person when I do this test?
Squeeze some fluid.
I am giving them more fluid, right? I'm kind of fluid challenging them.
Where do you put your hand? Sorry.
Right to the belly, just put pressure. So, just stand up for a minute. So if you're laying down, all you do is you just put pressure right up here. Just firm pressure right in the epigastric. So go this way. So you just put pressure right here. That's it. Okay, so we want to auscultate for bruits. So bruits are a sound that's made when you have an artery that's partially occluded. If it's completely occluded, would I hear a bruit? No, because there's no flow that's increased. The velocity is not increased. Because that's what you hear, is the increased velocity through a smaller tube. So we're going to do the temporal. Okay, we're going to do the carotid. Okay, you're going to do the aorta. You're going to do the renal. You're going to do the iliac. You're going to do the femoral. Okay, and you always use the bell. B equals B. Brew equals bell. Bell equals brew. I put the LR, the likelihood ratio, that seems Greek to you right now. Okay? It's 7.3 diagnostic for peripheral vascular disease. Okay? So you can do listen to the femoral, and you hear a bruit. You guys remember the 20, 50, and 80? So if you think they have about a 50%, I'm just going to give you some quick numbers how this works out. You can calculate it if you want. But if you have a 50% chance, you think, you talk to this patient, they say, yeah, I walk and it does hurt and stuff, and you get this patient and you think, I think this person has a 50% chance of having peripheral vascular disease, and I put this stethoscope on their femoral arteries and I hear bruits, it goes up to about 85%. Okay, I think the math is about that, maybe 82, maybe 81, I don't know. But that's, so I just jumped from I think to I know. And I better send them to the cath. Better send them to a surgeon, to a vascular specialist. Okay? Okay, that's why it's important. That's why you do the test. That's the areas, remember when you put it on an abdomen, your aorta's just left of midline, okay? So you can put it midline, but put just a little bit left. Your renal arteries bifurcate or come off of the aorta about midline between your belly button, okay, and the xiphoid process, and go about halfway out, so mid-clavicular line. Okay. Your iliac, same thing. If you could separate from the pubis bone to your umbilicus, they come out about halfway, and they're mid-clavicular. Okay. Your femoral is the iliac crest, okay, and the pubis bone is about halfway in between there. That's where you're going to place it. Pulses you're going to palpate. These are the pulses you're going to palpate. Okay, you can palpate the temporal. You guys will learn why we do this a little bit later. in neuro. Carotid, brachial, ulnar, radial, femoral, popliteal, dorsalis, pedis, posterior tibial. Hardest ones, lower extremities. Femoral's easy, it's a big pulse. Dorsalis, pedis, posterior tibialis are hard. If my femoral pulses are diminished, the LR ratio is 6.1 for peripheral vascular disease. Okay? If you diminished here, can't palpate those, it goes up to 14. So it's, if I thought 20%, it goes up to just about 90%. And I now know that they, pretty sure they have it. Same thing with the, you can feel the same type of waves in different pulses, it's just less than what you get with the carotid. You can feel them. Okay? You always should palpate bilaterally, you know this. Okay? Now, to palpate the popliteal is behind the knee. Okay? It's a deep pulse and it's difficult. The best way to do it is actually have a person bend their knee, okay? And have them lay flat and bend their knee. Or have them, they could be sitting and have their knee bent. Sometimes people actually have to have them lay on their stomach and bend their knee a little bit to get into that area. Okay? The posterior tibia is behind the tibia, right? So you guys know where the tibia is? Medial, right? The medial malleolus. Okay, right? This is the fibula. Medial malleolus. The best place, this is a very difficult, this is one of the most difficult secondary to the popliteal. It is posterior and down, okay, inferior, 2 centimeters. 2 centimeters back, 2 centimeters down. That's the best reference point. If you can't find it when we practice, I will find it on you, and then you'll know where it's at. It's really hard. Okay? Dorsalis pedis on your foot. It's on the top. It's behind the first and second digit, between the first and second digit. You find the navicular bone and just rotate medial a little, lateral a little bit, you'll find it. You guys learned this, how to document pulses. Normal is 2+. Okay. You always document this. And what you do is you have a person that's how you document it along the body. That's a really easy way to do it. And you can do if you do the tempo.
So do we draw this diagram when we document it?
Do what?
Do we draw this diagram?
You can, a lot of them, especially if you write it out, like in a hospital. If you do it on EMR, a lot of times they have that. You could also write so then you can put 2+ bilateral, right? So it's bilateral, radial, blah, 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 blah. Okay. So edema of the extremities, we talked about this already, I know. But this kind of shows you a good idea of how to do, you always do it in millimeters. So 2+, 1+, 2+, 3+, 4+. So patient has 1+ pitting edema. that means 2 millimeters. Patient has 2+ pitting edema, that's 4 millimeters. Patient has 3+ pitting edema, it's actually 6 millimeters. It's an estimate. I mean, you can measure it if you want. But it's in millimeters that the depth is. And then you write it as +1 + 2 + 3 + 4. Limb circumference, one of the most important tests you do that most people don't do for a deep vein thrombosis. Okay, patient comes in, leg pain, and red, leg pain and red. Okay, so the venous system, they got a clot in the vein. You better measure their calf, mid-calf. If I have an artery occlusion, what would my limb look like? Pale, white. Does it hurt? You bet. Because if I obstruct the blood flow going down the artery, my limb will look white, pale. If I obstruct the vein going back, which this is a deep vein thrombosis, I got blood there. That's why it's red. Okay? But it still really hurts. Okay? They've traveled, women on birth control, they smoke, history of blood clots, but you have to measure both legs. So if anyone comes in with leg pain, measure their calf. This is a very important test. If you measure it, don't guess where you're going to put your tape measure. Okay? Because one place will be different than another. So what you want to do is mark a leg. If I have a leg here, and here's my medial malleolus, okay, and here's my beautiful drawing. So say this is about mid-calf, okay, I can eyeball it. What you want to do is you want to take your tape measure and put it on here, okay? And you always do it in centimeters. So take your tape measure, put it on here, and measure up, and put a pen mark, and say it was 30 centimeters up, okay? And then measure the circumference around. I'm going to mark the circumference around, and whatever it is, 27 centimeters of the right leg, okay? Then do it on your other leg the exact same way, because there's not a big difference in length, okay? They're about the same. So measure 30 centimeters up and do that circumference. If this is 30 centimeters, you got a problem. So if it's greater than 2 centimeters difference between the circumference, you better worry. Okay? That's how you do a leg circumference. Any questions? Okay, Homans. I'm going to teach you this, but this is a dumb test. And the reason we're going to teach this is because you're going to hear your preceptor say, did you do a Homans, or was a Homans positive or negative? This is someone who comes in, same thing, leg pain, red, travel, blah, blah, blah. You think you're suspecting a DVT. What you do is you do a quick dorsiflex. So you grab the bottom of the foot and you dorsiflex it. Pull the foot up, right? And if it elicits pain, that's a positive Homans. Let me tell you why it's stupid. It gives you a lot of false positive tests. So I come in with calf pain or leg pain. How many times am I going to get a positive Homans test if I tore my calf? Yeah, kind of crawling with each other. You know, I was doing some exercise and, you know, I strained it. Or I have a cellulitis. of my lower leg and I stretch the skin, what's gonna happen on a Homan's test? So it doesn't distinguish between different types of capping, so, but I'm teaching you it because you're gonna hear the word out there, so now you know it. And it will probably be on a lot of times it's on a word question, a positive Homan's, so. Now you know it, learn it, think about why you really do it and what it tells you, okay? Break?